Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone to week 5 of Basic Dermatology Curriculum organized by Saudi Society of Dermatology and Dermatological Surgery. My name is Leen Alturki and I will be the session moderator today, inshallah. Firstly, I would like to thank you all for joining us. This session is being recorded and it will be made publicly available along with the course content on a Society official platforms on a social media after the course completion. Please feel free to type your questions in a chat at any time and we will address all the questions during Q&A segments at the end of the session. Our session today will be delivered by Dr. Abdullah Al-Amri. Thank you, Dr. Abdullah, for joining us today. It's our pleasure and honor to have you with us.
Hi everyone, good evening. Thank you, Dr. Leen, for your kind invitation to this lecture. It's going to be very easy, to the point, precise. The title is going to be the red leg, which is going to be in two parts. The first part, which is very common condition we have here, which is stasis dermatitis. The second part going to be a little bit in more depth, which is about ulcer. Feel free to ask any question. I'm gonna try to answer during the lecture itself to be more to the point of the information that we have here. So starting with the first part, which is stasis dermatitis, it's a very common thing. So we have two part. This condition have two part of the risk factor. So the first one, which is the most important part, we have somewhat of venous insufficiency, and this is a chronic venous insufficiency. So the pathogenesis of this venous insufficiency is very easy. We have risk factor, which is mainly going to happen patients with immobilization, long-standing obesity, taking oral contraceptive, and a lot of risk factors. So what happened, and really, these patients will have incompetent bowels, which is mainly happen in the lower part of the extremities. These will lead to leakage of a lot of things, mainly protein, fibrin, fluid, hemosiderin, and they will present in the first initial sign as a stasis purpura, which is the first part of stasis dermatitis. Then the patient will have a chronic inflammatory dermatitis, mainly eczematous dermatitis, that will lead to stasis dermatitis. At the end result, we have chronic fibrosis, which is going to be in two parts: acute lipodermatosclerosis and a chronic lipodermatosclerosis, which is part of paniculitis. An important part, these patients may be complicated by different other things, which is, can be irritant factor, superinfectious factor, that may complicate the picture that we have here. So when we mean complication factor, we have different other things. I'm going to just highlight a few things. The first one, the patient who have a stasis dermatitis taking somewhat of antibiotic like bacteriocin or neomycin, they may have risk of causing an ulcer. Another derivative factor is called lanolin, which is found in emollient, which is derivative also from wax wool alcohol. These patients may have risk of causing ulcer and stasis dermatitis. Other irritant part may also lead to maceration, increased inflammation, which is also complicate the picture that we have here. طيب. So we have two parts of the first part, if you can see the left picture, which is stasis purpura, which we have hemosiderin deposition in the papillary part of the dermis. So we can find dark blue, gray, sometimes dark brown pigmentation, as we can see the first picture here. If you move to the right picture, this is the second stage. So what happened here, it's going to happen later on here. So we have eczematous part presentation, somewhat of maceration, and the patient present with highly pruritic presentation, and of course we have excoriation at the same time. Moving on to the third stage, which is acute lipodermatosclerosis, which is become found hard in duration, which is mainly present in the medial part of the eye, up to the moving on to the ankle here. The chronic part, which is a very characteristic presentation, which is chronic lipodermatosclerosis, is part of stasis paniculitis. It's called inverted wine bottle, which is a very unique MCQ question, of course, also a morphological question. طيب في نقطة جدا مهمة I'm gonna mention we can find you can see it a lot in the clinic. Any patient that come to you with eczematous presentation, different morphology that can you found in the hand, in the abdomen, just a little bit widespread. Always examine two parts. The first part with the anterior chin, looking for stasis dermatitis, which is the second highest risk factor for the reaction, and look for the web spaces for any TNP, which is the most common risk factor. صراحة pathology not needed here, but I'm just gonna mention what we can find in stasis dermatitis. We can find the fibrinoid deposition along the blood vessel itself, somewhat hyalinized, thickening papillary part of the dermis, few RBC extravasation, which indicates the stasis purpura presentation of stasis dermatitis. However, it's a clinical diagnosis, nothing needed here. طيب في التريتمنت we should treat the underlying risk. So we mentioned we have venous insufficiency and we have eczematous dermatitis. So in venous insufficiency, if it's not really ulcerated, we treat by two important factors. The first, compression therapy, based on the stage of the venous insufficiency. So class 1, 2 compression stocking is usually enough. Or we can use multi-layer bandage and multiple times per day. However, always avoid and rule out this patient does not have peripheral artery disease and does not have congestive heart failure because it can complicate and may lead to risk of causing arterial ulcer. Then we treat underlying cutaneous inflammation. So topical anti-inflammatory like steroid based on the underlying severity, we have different classes. And topical, of course, immunomodulator like tacrolimus. Then we treat this and restore the skin barrier by using emollient and different other things. And we treat the underlying secondary infection or colonization by different factors. We can use topical antiseptic like chlorhexidine or topical antibiotic like mupirocin. There is underlying infection for these patients. So we treat based on the underlying risk factor of eczematous, we treat the eczematous part, and we treat the venous insufficiency part. نقطة جدا مهمة that you may encounter during the on-call. A lot of maybe specialty will not really differentiate between stasis dermatitis and cellulitis. It's mainly a morphological part, but I'm just also going to mention the history part. So cellulitis is not going to present within a few months or weeks, which is going to happen in stasis dermatitis. The morphological part, stasis is mainly bilateral, cellulitis is mainly unilateral. However, in eosinophilic cellulitis, which is a very rare thing, however, it's a very important MCQ question. It can happen sometime bilateral presentation. So the presentation is it's both ill-defined. Here is mainly eczematous. Here is mainly present as a painful, tender, warm, erythematous plaque presentation. However, it's both ill-defined at the same time. طيب هذه خلاصة السيس dermatitis very easy very straightforward ما في شيء عليها أبدا صراحة. Moving on to the second part which is about ulcer. What is the meaning of the ulcer? Ulcer بمعنى we have epidermal and dermal. Based on the thickness of the ulcer, we have different depth of the ulcer itself. We have different risk factors, different causes. The most common is three. The most common one is venous. Then we have arterial and we have neuropathic, which is common in Saudi because of the diabetic population we have here. How can we differentiate different type of ulcer here? Very easy. So in venous, it's mainly happen in the medial meningi, and it's sometimes grow faster or wider than other type of ulcer. في الارterial mainly happen the pressure point, lateral part of the feet, and also distal part of the fingers at the toes. Neuropathic mainly happen the pressure point like the great toe or the pressure point of the heel of the foot itself in this case. في المورphology here is shallow, sometimes exudative, sometimes aggregation have tissue and fibrinoid base. Here is very dry, necrotic and pinched out ulcer as neuropathic. لكن الفروقات الأساسية as the secondary finding. في الارterial ulcer we have the shiny skin because we don't have a good blood supply. So we have shiny atrophic skin, loss of hair, loss of peripheral pulse. Of course, we have cold feet. In neuropathic, we have thick callus surrounding the ulcer because we have like chronic pressure effect because the patient will have low sensation and we have a chronic mechanical effect on the ulcer itself because he doesn't really feel it. For venous, we have the secondary finding, as we mentioned before, sometimes stasis burbera, stasis dermatitis, lymphedema, and sometimes pinpoint petechiae you have in the same location. طيب الفينس ألسر which is the most common type as you can see here زي ما احنا قبل قلنا على الفينس insufficiency we have different risk factor family history obesity long standing pregnancy of course الفروقات الأساسية بالنسبة لي is few things في الارتيري ألسر it's always painful even in rest it's painful here لا it's improved during leg elevation which is very important مقارنة مع الارتيري ألسر. As you mentioned before, we have different other secondary findings, pinpoint petechiae, edema, lymphedema, cystic dermatitis at the same time. How can we approach these patients? The first thing, doing ankle brachial index to rule out this is not really arterial ulcer, doing neuropathic examination for these patients, looking for secondary morphological finding. قبل ما نقولها this is a venous ulcer at the same time. We can confirm it with a duplex ultrasound or we doing venography, however, it's not really needed. The most important to rule out other causes like arterial ulcer or other causes of ulcer in these patients. طيب you can see venule ectasia. Um, pathology however the different factor اللي هو الستين
المعذرة دكتور عن المقاطعة بس صوتي
in these patients مقارنة بيتروكوبيساركوما. صوتي يقطع.
بس كان قطع قبل شوي.
الو.
أيوة دكتور.
طيب زي ما احنا قبل هذا سودوكوبيساركوما which is venous insufficiency part of venous ulcer بس ان الفكرة الأساسية the same as كابوسي. الفرق الأساسي اللي بينهم بس اللي هو الستين حق الكوبيساركوما which will be negative here and positive there. طيب وش التريتمنت any type of ulcer كل التايب في فروقات بسيطة بينهم بشكل عام. It's five important factor. Moisturization and occlusion however should avoid an infectious part of ulcer. Debridement dressing and treat the underlying infection, treat the underlying colonization of infection and adjuvant wound care for these patients. طيب نروح النقطة الأولى اللي هي debridement avoid an arterial ulcer of course. في نقطتين جدا مهمة بالنسبة لي اللي هو mechanical وأوتوليتيك. فكرة الميكانيكال debridement for ulcer اللي هو نحط with goes then we dry it off يعني نحطه ونشيله بشكل عام. المشكله بالنسبه لي ان هذا الحاله it's not selective and it's very painful. في الاوتوليتيك لا نحط الويت جوز ونخلي الجسم using our proteolytic enzyme to enhance the area itself. هنا it's more selective and it's painless. However, both of these type of debridement we cannot use it in infected wound and arterial ulcer of course. في الدريسنج في كلام مره كثير it's a very huge table لكن بالنسبه لي في نقاط معينه في any dressing that appropriate for any type of ulcer to provide moist environment ما عدا كان infected part of ulcer absorb the exudative part of the ulcer itself treat underlying maceration protect against any infection release or relieve the pain and decrease the odor here. 2 points of dressing here. If any question that's come to you, what is the most important part of dressing that can relieve pain? It's going to be the hydrogel. Okay. What is the most important dressing that can relieve if it's we have high, very, very high exudative part of ulcer? It's going to be alginate because alginate is a fibrous dressing that provides homeostatic effect to the wound itself in this case. So hydrogel for pain, alginate for exudative part of ulcer. Of course, we treat the underlying infection. We have two scenarios for these cases. Infection, we treat based on the spectrum we have here. If it's a colonization, we use antiseptic like hydroperoxide, chloroxidine, and silver. نقاط مهمة مرة على السيلفر because it's a very important MCQs. Silver can cause localized acromegalia, can cause reverse neutropenia in children, and also can flare up the porphyria patient. طيب في الوند كير we have different points. الcompression, lymphatic drainage, back therapy, avoid in arterial part of ulcer. This is a very important part, only in venous ulcer. So on compression, based on the underlying presentation, so if it's elephantiasis, we can use higher pressure of compression stroke like 50 to 60. If it is just simple edema, simple varicose vein, 20 to 30 going to be enough. And this is a very important MCQ and high yield point. في الاورال تريتمنت we have different oral treatment صراحه. We have benazole and different fibrotic part of treatment لكن بس just I'm gonna mention pentoxifillin which is can be used in venous ulcer. It's a like a fibrinolytic, thrombotic, antithrombotic effect and using like 1200 milligram once daily for these patients. طب هذا كله we mention how to approach any part of ulcer, confirm and rule out arterial ulcer by using API ankle brachial index, screen for neuropathy, confirm this is a venous ulcer, doing our management protocol which is dressing, debridement, treat underlying infection and wound care of course. طيب الارتيريال ألسر زي ما احنا اتفقنا we have different morphology. First is dry, it's necrotic. The patient gonna be have cold skin, loss of peripheral pulse on these patients. Like the most important thing about these patients, it's very painful and also pain during rest, which is a very important differentiating factor on venous ulcer. كيف how to screen it? The first part always with ABI. We can confirm by invasive digital subtraction angiography, however, not usually needed in this case. The same treatment, avoid debridement, avoid compression therapy and back therapy for lymphatic drainage for these patients because they may complicate the arterial ulcer. And the treat underlying arterial complications with antiplatelets. Sometimes we can give the prostaglandin D3 inhibitor for these patients. في سب ديفيجن تحت الارتيريال ulcer which is الصورة هذه which is called martorial hypertensive ulcer. الفرق الأساسي اللي بينها يكون في ال posterior lateral leg rather than the lateral part of the feet here. طيب neuropathic which is common in Saudi, it is different risk factor on these patients. Trauma, infection, ischemia, different part that may enhance the neuropathic ulcer. زي ما احنا كنا قلنا قبل ان patient مقارنة مع ulcer we have really good pulse at the same time. نفس الانفستيجيشن نفس الابروach. Sometimes we can do MRI for these patients, especially we need to rule out the underlying connective tissue infection in the same time or the same region. The same treatment, but في 2 points we're gonna mention. Hyperbaric oxygen to supply the blood vessel that supply the peripheral nerve on the same area. المشكلة بالنسبة لي we have complication في هذه الحالة. Sometimes can have a barotrauma to the lungs, a myopia to the eyes, and of course seizure. Precapillary, which is recombinant platelet tissue growth factor F. However, in these patients take more than 3 tubes, and the patient have risk factor of cancer, may enhance risk of cancer on these patients. We have a pressure ulcer. Everyone knows it. We have most important the 4 stages of pressure ulcer, which is mainly happen the pressure point, sacral area, pelvis, distal part of the feet. So it's a pressure point ulcer. So we have 4 stages. The first stage, the emblastable erythema. Second stage, partial to the epidermis and the dermis. Third stage gonna be to the subcutaneous tissue. Fourth stage to the underlying bone, the muscle, and etc. في نقطة جدا مهمة بالنسبة لي اللي هو subdivision تحت sacral ulcer which is called Kennedy terminal ulcer. يكون شكلها sacral يكون في المكان sacral area butterfly appearance which is indicated higher mortality rate for these patients. The same treatment, however, we need to do surgery in the stage 4 in pressure ulcer. These are the location of pressure ulcer as we mentioned before, and also the depth and the stages of ulcer. طيب finally we have different causes of ulcer صراحة كثيرة مرة depend on the underlying stage. We have vasculitic, neutrophilic dermatosis, infectious cause, neoplastic which is the most common going to happen with the BCC. But I'm going to mention 2 things. The first thing اللي هو genital dermatosis, we have 2 parts. Patient with a clefenter mainly happen recurrent leg ulcer, familiar child plain lupus which mainly happen the hand with the TRIX1 mutation. اهم شيء بالنسبه لي ميديكيشن لان كل واحده لها different morphology و different location. في الهيدروكسيوريس mainly happen في الليجز. في الامتكس mainly happen with the psoriatic patients who can cause necrosis in psoriatic area. في التريتينوين all trans tretinoin mainly happen in the scrotum. والفورسكار which is very high yield MCQ can happen in the penile area. اتوقع خلصنا البارت بالسر بس ودي اسوي لكم 2 cases anyone حاب يدخل فيها او answer the question. صراحة حاب احد كذا يدخل ويعني يكون في كذا يعني مداخلات على الاريا هذه. This is the first case. This is a 45 years old male recurrent erythematous edematous plaque in the arm معها شوية burning sensation pruritus and leave residual hyperpigmentation. Anyone can answer this question?
إذا في أحد بس حاب يفتح المايك بس just raise your hand عشان أعطي
الصراحة شوية difficult. أنا ما أدري وش الليفل اللي موجودين هنا صراحة. يعني ممكن هذه R2 R3 ليفل. طيب I will try to answer it. طب هذه احنا قلنا recurrent صح؟ وإذا ما تستريت البت يعني هذه ما هي it's not stasis at all يعني. هي الأساسية اللي عندي بالنسبة لي في الباثولوجي we can see a lot of eosinophils. Okay. دقيقة إيه. A lot of eosinophils here. So eosinophils, a lot of flame figure, which is like collagen bundle integrated with eosinophils. So this is underlying eosinophilic cellulitis, as you mentioned before, in the differential diagnosis. The treatment gonna be steroid or any other immunosuppressive treatment, and possible association gonna be Strauss, which is a part of vasculitis. طيب second case anyone؟ أعتقد شرحناها بشكل كويس هذه. طيب ما هي مشكلة. This is a 68 years old female with a chronic shallow ulcer in the middle aspect of the lower leg with regular border, gradation tissue base, very highly exudative, and with leg edema, additional bedside examination, of course, going to be API, ankle brachial index, to rule out this is not arterial ulcer. What's the most appropriate dressing for these patients? We mentioned this is very highly exudative part of ulcer, so alginate dressing going to be fine with these patients. إذا هذا البيشنت جاء بعد فترة لقينا عنده irreversible blue grade discoloration, what the treatment can cause this condition, it's going to be silver.
There's the chat box. So the diagnosis is a venous ulcer, and the best.
أنا ما أدري صراحة، أنا ما أدري أوكي. bedside no gonna be ankle brachial index الفينس في الدوبلكس. يعني we can confirm our diagnosis، لكن الفكرة الأساسية لما أقول لك initial investigation not for confirming our diagnosis. However, we rule out other condition like arterial ulcer for these patients. وأعتقد إنه very good MCQ ترى هذه في الاختبارات. أنا صراحة ما أدري كيف أشوف الشات بوكس، ما أدري كيف الطريقة الأمانة.
يحتاج ترجع على الزوم.
أرجع أسوي بس أتوقع خلصنا. صراحة الألسر هو يعني مو مرة مهم as a topic في الإكزامز، بس هو مهم في الحقيقة. يعني that you can see a lot of ulcer patients especially during your own call. فمرة مهم تعرفون we need to take biopsy, what's the first screening to do these patients, أو what is the differential diagnosis اللي عندنا، لأن هذا المهم صراحة for these patients. وبس إذا عندكم أي سؤال feel free صراحة.
لا يعطيك العافية دكتور عبد الله على المحاضرة القيمة، أثرتنا حقيقة، ما قصرت، ألف شكر.